Welcome everyone to today's educational webinar. My name is Herman Groepenhoff. I'm the Senior Clinical Medical Advisor at Jaeger Medical and involved in all these educational programs. I'm delighted to have you join us for this very insightful session with Dr. Daniel Dumitrescu, a cardiologist from Bad Oeynhausen, Germany. He's educated in the US, so he can fluently speak English even better than me. And today, Dr. Dumitrescu will guide you through the vital topic of cardiopulmonary exercise testing, exploring the journey from clinical questions you will have to an effective reporting, how to report all this CPET data on your screen. I recognize, not that I followed all the CPET practical Wasserman courses, but he's already, I think, for more than a decade on stage covering this topic, and every time I learn something from him when I listen to him on stage. I only leave you with two practical points for this moment. For accreditation point, IARC from the US, you have to attend at least 30 minutes. And at the end, we will try to have 50 minutes of interactive questions and answers. From the history or from experience, we know we will have too many questions, but we will stop the session at least 10 minutes later. We have to stop somewhere. Again, welcome you and thank you for being part of this inspiring event. I'm already looking forward to this new education from Daniel Dumitrescu. So Daniel, please take over my microphone. I'll come back to you later.
Well, Herman, thank you so much for inviting me into this special format to give some insights on the nuts and bolts of cardiopulmonary exercise testing. And first of all, I hope you can hear me. Is sound okay? And can you see the slide on the screen?
Yes, I can answer for them. Yes, I see you clearly and we can hear you clearly.
Yeah, perfect. Then, dear colleagues, welcome to this online webinar on cardiopulmonary exercise testing, which is one of my favorite topics. I leave you with a disclaimer and thank the company, Jaeger, for enabling this format so that we have the chance to discuss and to share some thoughts on cardiopulmonary exercise testing together. This is the disclaimer. And let's start with the contents. Today we are going to talk about the nuts and bolts of cardiopulmonary exercise testing and go from clinical questions to reliable reports. And if we are talking about nuts and bolts of cardiopulmonary exercise testing, first of all, here are my disclosures for whom is interested. We have to talk about the philosophy of cardiopulmonary exercise testing. And the question, what is cardiopulmonary exercise testing, or what is it supposed to do? And one thing it is not supposed to do, it is not a magic black box where a patient with dyspnea or unexplained symptoms comes into your office or your clinic and you put them on the bike and the bike or the software or any algorithm tells you this is the patient's diagnosis. I think this would be too simple and this would overwhelm the method. Cardiopulmonary exercise testing is a very comprehensive method of giving you information on metabolism, give you surrogate parameters on hemodynamics, and this during exercise and at rest and in the recovery phase. So it's not something like a pregnancy test, it's more like a plane cockpit. And the greatest asset of cardiopulmonary exercise testing is the comprehensive and large set of data, but this is also its greatest challenge. So what is important? What are possible sources of error? And what do I really need to create a reliable report in my clinical practice? So today we are trying not to talk about all the instrument on the flight cockpit. We're talking about a simple car dashboard. So how do I get from A to B? How do I get from the clinical question to a reliable report? What basic information do I need from cardiopulmonary exercise testing? Another problem is this wealth of data is hard to interpret if you just look at the numbers. So what would be your diagnosis in this case? It would take a very long time until you worked yourself through these columns of numbers and try to reconstruct what has happened during this test. So you need some special kind of data display in order to do reliable interpretation of the test and to do it in a timely manner. So one thing is you need some kind of visualization of the cardiopulmonary exercise data. So you need a dynamic approach. And you need an approach that you can also read and differentiate on black and white copies. This was a test from a young man who had myocarditis 6 months ago. And we got this referral with the question, is the patient okay? And it is possible to differentiate between the first and the second test, but it is very difficult if you don't have any standard approach and if all lines look the same to try to figure out what parameter belongs to which scale. So you need some kind of a standardized approach. And just for the history of cardiopulmonary exercise testing and for interpretation, um, there was a large need for rapid evaluation of a large cohort of shipyard workers in the late 70s. The US Department of Labor approached the working group of Dr. Wasserman um, because there was a significant cohort of shipyard workers who had been potentially in contact with asbestos. And there was the question whether these shipyard workers would be limited in their exercise capacity and if they were showing a ventilatory limitation pattern. Because it was known that exercise limitation and lung function did not correlate, as you can see on this slide. So the group of Professor Wasserman was faced with the task, how do we exercise this large cohort of patients in a very short time window and do reliable interpretation? And two things were important for the group and for Professor Wasserman. Number one, you should have a visual data arrangement. This means you had to put the numbers into graphs. And the second aspect was everything had to fit on one page so that you were able to get all relevant information at first sight without having to skip several pages and going back and forth. And so as the end result, the 9-panel plot was born. So in 9 panels, all important information from the exercise study are contained, and you can look at these graphs without skipping pages and without going back and forth. So this would be, and this was becoming the new standard of cardiopulmonary exercise testing interpretation. There were several 9-panel plots or 8-panel plots at this time. In 2012, a new arrangement was published based on the suggestions of Professor Brian Whipp, which were previously published in the European Respiratory Journal in 2007. The 2012 version was a modification of this, extending the 8-panel plot to a 9-panel plot. However, the most important difference between the Wasserman 9-panel plot and the Whipp 9-panel plot is that VO2 is on the x-axis in the Whipp plot, while time is on the x-axis in most panels of the Wasserman plot. And then the Wasserman group itself rearranged the panels in their 2012 edition of Principles of Exercise Testing and Interpretation and arranged a new version of the 9-panel plot, which has a didactic advantage. So if you go from the upper left to the upper right corner, you have parameters of circulation. If you go from the upper left to the lower right corner, you have the ventilatory axis, this means all parameters that you need for evaluation of ventilatory patterns. And if you go from the upper left to the lower left corner, you have the ventilatory efficiency axis. So this means all parameters that tell you something about ventilatory efficiency. So general advice for optimized formatting: cover your free space as much as possible. So don't do mini graphs, but use the space you have on the sheet of paper because it makes the report much more legible. Use the same scaling for follow-up measurements in the individual patient because this enables you to see differences in long-time follow-up much easier than if you use different scaling. As you've already seen on this black and white copy that I've shown you, single parameters must be identifiable even in black and white printouts. And most importantly, perform a dynamic visual interpretation of the data because cardiopulmonary exercise testing is no static test, it's a dynamic test. And what you want to see is the pattern of limitation when patients come to you with unexplained symptoms or exercise intolerance. And we thought, well, 9 panels, 9 questions. So if you want to do a systematic interpretation, this is a suggestion of systematically going through these panels and asking several pathophysiological questions in order to perform a systematic review of the test and to write a systematically identical report for each test and each subject. So the first question that you would be interested in: why did the subject or why did the patient stop? And the only way of getting the answer is asking the subject, of course. The second question: while the subject is already sitting on the bike and doing the resting phase, are the measurements plausible? This means, is calibration correct? Do you have to redo the calibration? And do you have valid measurements? And an easy way to look at is by looking at the parameters that you have calibrated before the test. This means you start with ventilation. Is resting ventilation in these patients around 9 to 10 liters per minute? Is the oxygen uptake, VO2, around 3 to 5 milliliters per minute per kilogram? And is the relationship between CO2 output and oxygen uptake as you would expect it? And the ratio of CO2 uptake, output and oxygen uptake is the respiratory exchange ratio, the RER value, which should be between 0.7 and 0.9 at rest in the subject. If you have higher values of RER, this is usually done by hyperventilation of the subjects. So if the patient or the subject has an RER of 1.0, 1.1, you should also see that minute ventilation should be higher in these patients. If you have an RER value of 1.1, 1.2, and a lower ventilation that you would expect, then the probability is high that you have to redo calibration before the subject starts pedaling, because you would not have to retest the patient on the same day. Question number 3: is it a valid maximal effort? And this is a crucial question which you can answer much better if you have metabolic information as you have it in cardiopulmonary exercise testing. If you do regular ergometry, you have to rely on the subject's expression. So what does the subject say at the end of the test? You have to rely on ECG abnormalities, on blood pressure, and maximum heart rate. And if patients are taking beta blockers, your validity is impaired to say whether the test has been maximal or not. If you have metabolic information, and here you especially have RER, it tells you about the relationship between CO2 output and oxygen uptake, and thus it tells you how far the patient or the subject has gone into their anaerobic metabolism. And this is a major advantage over classical ergometry without gas exchange measurements. Furthermore, you can of course look at the heart rate like in ergometry, and you can look at the breathing reserve. So if a patient does not have any more breathing reserve, it is a valid maximal effort because there is a ventilatory limitation, and no breathing reserve means the patient has to stop and is not voluntarily doing this. The next question, of course, is if the test is valid, what is the maximal exercise capacity? Is the subject or the patient limited? And if yes, how, at what degree is the limitation? And the main parameter that you would need for the clinical setting is peak VO2. And this is the maximal oxygen uptake that the patient has reached at one exercise test. If you want to really do a VO2 max, you have to do several tests with increasing maximal workloads and see whether the peak VO2 that the patient or the subject is reaching in these single tests is the maximal VO2 that they can reach even with increasing work rates. For clinical purposes, peak VO2 is completely okay because you do an incremental exercise test, the patient stops, and if it's a valid maximal effort, peak VO2 tells you enough about the patient's maximal exercise tolerance. But not only look at peak VO2 as a number, also look at the pattern of how peak VO2 or of how VO2 increases. Because it is a fixed relationship for ergometry work. The slope of increase in VO2 is 10 milliliters per minute per watt. And this is independent from your age. This is independent from your height and weight. It's always 10 if oxygen transport is functioning physiologically. Obese people have a higher VO2 at a given work rate compared to a normal subject. However, the reason for this is already in the warm-up phase, the obese patients have to move much more body weight so that VO2 is rising above the VO2 of normal subjects already in the resting phase, but the slope remains the same. If oxygen transport is limited, and this is the prototype of heart failure, you cannot reach these 10 milliliters per minute per watt, and thus the slope is blunted. The question is, how can you recognize this? Whether you are reaching these 10 milliliters per minute per watt or not. And it is pretty easy. First of all, you have to show the predicted value for peak VO2 on the graph. And for this relationship, you have to plot VO2 and workload with a ratio of 1 to 100 if VO2 is measured in liters per minute. Or you have to plot it with a ratio of 10 to 1 if VO2 is measured in milliliters per minute. So this means 3000 milliliters of VO2 equal 300 watts. 2000 milliliters of VO2 equal 200 watts, and so forth. This means if the curves of work rate and VO2 are climbing in a parallel fashion, you have this relationship of 10 milliliters per minute per watt. And this is a diagnostic feature that you can visually determine on the 9-panel plot. Because if the slope of VO2 is blunted, does not increase with a 10 milliliter per minute per watt ratio, like you can see it in this right panel, patient with heart failure, you know that there must be something wrong with hemodynamics or oxygen transport. This is what you would physiologically expect to see. VO2 climbing with 10 milliliters per minute per watt over the whole exercise period. However, this is another feature that you regularly see in patients with cardiac limitation. So VO2 is climbing with 10 milliliters per minute per watt in the first part of the study, and then it flattens and may even reach a plateau at the end of exercise. What does it mean? It means that cardiac output cannot be adequately increased from this point on, and there is a circulatory limitation at this point. So the prototype of this pattern is myocardial ischemia, but other pathophysiological features that may cause an impaired increase in cardiac output may also reproduce this pattern. So you are not specific to say this is myocardial ischemia, but you are able to say there is something wrong with exercise hemodynamics and oxygen transport while at rest and lower exercise. It is normal. So this is the prototype of a circulatory limitation pattern. For example, dynamic mitral valve insufficiencies may produce the same pattern as this. So the diagnosis is still up to the physician who interprets the exercise study. Next question. Is submaximal exercise capacity impaired? And this is the anaerobic threshold concept, or VT1, as there is a standardization paper from the German working group on these threshold models. So VT1 means the same as AT in the US. So what is anaerobic threshold, or what is the concept that is behind this AT or VT1 parameter? You have a certain oxygen supply at rest and a certain oxygen demand. This is obvious. And if you exercise with increasing intensity, your oxygen demand, of course, becomes higher, and your oxygen supply also becomes higher, but it increases with a constant slope. This is what we have previously discussed. So there will be a point during exercise where your oxygen supply just meets your oxygen demand. And above that point, oxygen supply is lower than oxygen demand. So you have to add anaerobic metabolism to your aerobic metabolism in order to continue exercising. So what is the clinical benefit of this AT or VT1 concept? Well, you can predict whether a low VT1 may be due to deconditioning or if there is a manifest pathological process behind it. And there have been studies of Professor Wasserman who have suggested a threshold of less than 40% of the peak VO2 predicted value. So this means you take your VT1, which is measured as a VO2 value, and compare it with the predicted peak VO2 value, not with the achieved peak VO2 value. And if it's lower than 40% of the predicted peak VO2 value, then it is very probable that there is a pathological process, again, the prototype heart failure, underlying exercise limitation. For plotting, use an identical size and scaling for VO2 and VCO2 on the V-slope panel, and take a slope of 1 when using the V-slope method. In this plot, and this was a healthy subject, you can assume, well, VO2 versus VCO2 changes at this point. So you would have an anaerobic threshold of around 0.7 liters of VO2, which would be quite low. But the problem is this slope line is not a slope of 1, it's less. And if you take a slope of 1, you see that the AT point is much higher. And this is the correct slope. It has to be 1. And the point where VCO2 versus VO2 increases to a slope of more than 1 is the definition of the anaerobic threshold, or the VT1. So you have to be careful with this slope, that it's correctly set at 1. Use an identical time axis of all panels in the left 2 columns, because time is always on the x-axis, and it's much easier to compare a certain point in different panels if you have the same scaling for all panels in one column. For the determination of VT1 or the AT, the whip plot is especially suitable because it has VO2 on the x-axis in all three panels of the left column, so that the visibility of this point is very sharp. This panel, which is used for AT determination, also has another plot on it, which is heart rate versus VO2. And plot the intersection of the predicted values for peak VO2 and heart rate onto this panel. So this means you take the predicted values from heart rate and draw a line towards the right. You take the predicted value of peak VO2 and draw a vertical line. And the intersection point is the so-called Hansen X, because Professor Hansen, he took great value to have this intersection point. Why? Because it tells you something about efficiency of circulation. So you need the oxygen pulse concept, and this is VO2 versus heart rate, in order to evaluate circulatory efficiency. And today I will show you this plot because it contains relevant information and it contains relevant pathological information that you can easily visualize. So this is what you would expect from a normal subject. If you are healthy, you go towards your predicted values with VO2. This means you aim at going to the predicted value for VO2, but you also aim to go to your predicted value for heart rate. And this means the point of VO2 versus heart rate point towards the intersection of these two predicted values. This is obvious. And if this is not reached, like you see it in the right panel, this was a young lady with a severe pulmonary arterial hypertension and severe exercise limitation. She was very active before the onset of the disease, but when we first put her on a cardiopulmonary exercise test, you see that the slope is much steeper of the points of VO2 versus heart rate, so it does not point towards the trajectory of the predicteds. And the points of heart rate versus VO2 are becoming much steeper at a higher exercise intensity. What does it mean? It does mean that there is a massive hemodynamic problem. You see that she stops at 0.6 liters per minute. And this is a very low peak VO2 rate. It was, I think, 30% of her predicted peak VO2 value. But you see that heart rate is increasing very steeply. What is the underlying mechanism? Cardiac output is not able to increase adequately beyond this point. So there is a reflectory attempt to increase cardiac output by increasing heart rate. But this does not work for a long period of time and the patient stops very early. So without looking at any other results or tests, you can tell that this young lady has a significant hemodynamic problem during exercise. And this is what you can easily visualize in the 9-panel plot in a cardiopulmonary exercise test. Next question, is ventilatory efficiency impaired? So we are not only looking at maximal values, we are also looking at efficiencies, and not only circulation, but also ventilation. And ventilatory efficiency is important because it tells you something about the pulmonary ventilation perfusion relationship. At rest, if you are healthy, you need about 30 to 40 liters of minute ventilation to eliminate 1 liter of CO2. And this is only possible if diffusion is functioning properly and if you have enough perfusion in the pulmonary circulation. What is happening if you exercise? You recruit more pulmonary vessels and you recruit more pulmonary vascular bed. Thus, you are much better able to eliminate CO2. And this means the relationship of ventilation to CO2 output must decrease if you are healthy. And it decreases to values between 20 and 30. Fitter people usually go more towards 20. Unfitter people usually go more towards 30. But if you have a patient with unexplained dyspnea and a ventilation or ventilatory equivalence, a VE-VCO2 relationship of more than 30, 32, 34, especially in young people, you have to expect that there is something wrong with the ventilation perfusion relationship. And the prototype of this is pulmonary arterial hypertension or chronic thromboembolic disease, where a part of the pulmonary arterial vessels are blocked or structurally damaged, so that CO2 is retained in the pulmonary vasculature. And there is the dilution effect because you have very well ventilated lung that is poorly perfused. And patients start hyperventilating because CO2 is a strong ventilatory drive, or better said, it is the ventilatory drive during exercise, so that they have to breathe a much higher amount of minute ventilation in order to eliminate the same amount of CO2. And this means the VE to VCO2 ratio increases. And this is what you see here. This is a patient with scleroderma and associated pulmonary arterial hypertension that is starting at 45 liters of minute ventilation to eliminate 1 liter of CO2. And during exercise, these patients do not become more efficient in their breathing, they become more inefficient. And at maximal exercise, this patient has to breathe more than 55 liters per minute in order to eliminate 1 liter of CO2. So this is almost 3 times the amount of the healthy subject. And this is one reason why these patients have massive dyspnea. And on the other hand, it tells you something about the ventilation perfusion relationship. However, there are other potential causes for elevated VE-VCO2 ratios. And basically, it's everything that may disturb the pulmonary ventilation perfusion relationship. So, one common cause is voluntary hyperventilation. You artificially increase dead space and thus alter the ventilatory side. Same applies for obstructive lung disease. You have a ventilatory problem, which impairs CO2 output, but you may also see high VE-VCO2 ratios in chronic heart failure. And of course, cardiac shunts, especially those going from right to left, produce high VE-VCO2 relationships. Next question, is there a ventilatory dysfunction? This means you have to look at the breathing pattern, at flow volume loops, and you have to check whether there is adequate breathing reserve or if patients are ventilatory limited just because their breathing reserve is exhausted. And this is a prototype of a normal healthy subject. So during exercise, first you increase your tidal volume, then you increase breathing frequency, and physiologically, you have a breathing frequency between 20, 30 to 50 breaths per minute at the end of exercise. If you have a restrictive pattern, such as pulmonary fibrosis or other interstitial lung diseases, you are not able to increase your tidal volume as much as the healthy subject, and you go into a rapid shallow breathing pattern. And this patient had a maximal breathing frequency of almost 50 breaths per minute with a blunted increase in tidal volume. And this tells you something about a restrictive breathing pattern. This is an obstructive breathing pattern. It looks similar. Patients are not able to increase their tidal volume adequately, and they run out of breathing reserve. And this is the point where every subject or patient has to stop. If you don't have any more breathing reserve or less than 10 liters per minute approximately, it is a very negative subjective feeling and you have to stop exercise. And this is obvious ventilatory limitation. Last question, does it all make sense? So you have to go through every of the 8 questions and ask yourself, well, does it make sense? Am I able to answer the clinical question? Or is there anything that is just wrong with this test? And if there is something which is obviously wrong with this test. You have to identify what is wrong and why is it wrong. Last but not least, and I think this is important for creating reports. This is the, well, what's in it for them concept. You are asked a clinical question if you do an exercise test, and somebody orders this exercise test and does not necessarily be as passionate about cardiopulmonary exercise testing as you are. So you have to be interested in concisely answering the clinical question so that is understandable for the patient, for the physician or person who ordered the exercise study. So this means you have to identify, well, who are they? Who asked the question? And what is the question? Just to show you an example of two exercise tests. So this was patient one. It's all in German and you don't have to read the details. But this was a patient with unexplained exercise limitations that came to, I think, four expert centers before. And we were the fifth center who were to evaluate this patient. Of course, then you have to write a very comprehensive report on what you see and what you think about the mechanism of exercise limitation. And there was another question from our surgical department. It was, is the patient eligible for heart transplant? Well, what is peak VO2? And this report was very easy to answer and didn't require as comprehensive a report as for patient one. So last but not least, I have brought a clinical case where we can really systematically go through these questions. So this was a 32-year-old female which came to our department for a clinical study. So she was asymptomatic. It was a study for healthy people. And she performed an exercise study on the bike. And what we saw was the oxygen uptake was pretty low. And so let's go through this case in a step-by-step manner based on these 9 questions. So why did the patient or the subject stop? It was because of leg fatigue. She said in her daily life, she didn't have any problems with exercise capacity. She was preparing for a half marathon and did not have any previously known disease. So are the values plausible that we obtained at rest? And we looked at that. VO2 was 350 milliliters per minute, which was approximately 3 to 5 milliliters per minute per kilogram as we requested it in the previous part. Minute ventilation was 8.5 liters per minute and RER at rest was 0.9, so perfectly okay values. Next question, was it a maximal test? RER at peak, you see this in panel 8, was at 1.2. So this patient exceeded her anaerobic threshold and was deep into anaerobic metabolism at the point where she stopped the exercise study. So it was a valid maximal test. Maximal exercise capacity. She reached a peak VO2 of 1.7 liters per minute, which is equal to 29.8 milliliters per minute per kilogram. And this was 67% of her predicted value, which is pretty low. So the next question is, what was her anaerobic capacity or aerobic capacity? Where was her anaerobic threshold? And the anaerobic threshold was at 800 milliliters per minute, and it was 33% of the predicted peak VO2. And as we have learned, she was below the threshold of 40% of predicted peak VO2. So this rose suspicion that there was something pathological going on, although the patient was completely asymptomatic. Then we looked at circulatory efficiency. Was it impaired? And as you see, I'm trying to move away my picture column. Yes. In panel 3, you see the X value, so the intersection of the two predicteds of heart rate and VO2. And the slope of the dots of heart rate versus VO2 plot are not going towards this X value, but you also are not able to identify an upward movement of heart rate as we've seen it in the PAH patient. So it's completely linear. And this does not really fit together. Next question. Is ventilatory efficiency impaired? And this is the ventilatory efficiency axis. So we look at VEV-CO2 slope, which was 29, which was normal. We looked at the lowest VEV-CO2 value during exercise, which was 28. And we looked at the highest end-tidal CO2 value during exercise, which was 43 millimeters of mercury, so perfectly normal values. Next question, is there a ventilatory impairment or dysfunction? She was able to increase her tidal volume from 0.5 liters to over 2 liters, and she was able to increase her breathing frequency, and she showed a completely physiological breathing pattern, and she had plenty of breathing reserve during exercise. Now we come to question number 9. Does it all make sense? And this is what I was talking about. You have an asymptomatic patient with a limited maximal exercise capacity with a low anaerobic threshold, but no other signs of a specific limitation pattern. And so, no, this does not make sense. So we were thinking about what is wrong with this test or what we should do as the next diagnostic steps. And it was really striking that only VO2 was altered in this patient and nothing else. And it was altered in such a way that we said it could not be due to physical deconditioning. It had to be something pathological. And this led us to the thought that we had to check the values that we entered into the system. And if you look at the values, well, height and weight were entered correctly, but Stephanie was male in the system. So the wrong predicted values were used. And this was the key to interpreting this exercise study, because if you took the correct predicted values, she was perfectly normal. She achieved a value of peak VO2 that was 93% of her predicted. Her VT1, or the anaerobic threshold, was now 46% of her predicted peak VO2, and the other parameters were okay from the beginning. So we have a completely normal test, which now makes sense. And this is an important point. Try to identify what is wrong with the test, because sometimes it's the easy things. It's either calibration or it's skipping weight and height and entering them into the wrong place. It's mistaking the patient's sex, so entering male instead of female or the other way around. And these are things that you have to identify, because otherwise you don't get reliable results. But if you take a systematic approach, you will get reliable results when you interpret cardiopulmonary exercise studies. If you want to have more detailed information on data display and interpretation strategy and pathophysiology of cardiopulmonary exercise testing, there is a whole issue of the Annals of the American Thoracic Society, which was published in 2017, which is accessible free of charge, and where you can get sufficient and more detailed information if you are interested. And now I thank you for your attention, and I'm happy to answer your question and look forward to that. Thank you.
Thank you, Daniel Dumitrescu, for again, as I know you, for a clear, straightforward interpretation lecture about CPET, making it look like very easy, which it can always be much more difficult than it is. But I think it is not that difficult if you take your approach strategical. And yes, we already have some questions. I will read them for you
Yeah.
very quickly because, and again, we have 20 minutes. So our blood gases you didn't mention, and it was all about gas exchange, but the question about blood gases or arterial lactate, do you use them in your practice and why or why not?
Yes. If you have a blood gas analyzer, use it as often as you can. Um, what is the advantage of blood gases, or what is the additional information? It is very useful for lactate levels to compare the anaerobic threshold that you have measured by gas exchange with lactate levels. And we had some patients who came in with unexplained dyspnea and did not have any signs of circulatory impairment or heart failure on echo or lung function, but they had excessively high lactate levels at low exercise work rates. And these were patients who had peripheral muscle disease. So lactate may be an indicator for oxygen extraction problems that are chronic. Lactate alone, I think it's not a good measurement. So if you do blood gases, measure lactate and also measure PO2, PCO2, because it tells you something about lung diffusion during exercise. If you take the alveolo-arterial oxygen content difference, the AADO2, and it also tells you something about physiological dead space during exercise. You are only able to determine dead space, and this is important for the differential diagnosis of low ventilatory efficiency. You only know ventilatory dead space if you have blood gases. There are some algorithms that calculate dead space by using end-tidal CO2 as a surrogate for PCO2, but this is not valid if the patient has a diffusion problem, and this is what you want to find out in the end. For healthy people, it works, but for patients with limitations, and especially pulmonary or pulmonary vascular limitations, it does not work. You need PCO2 and PO2 to really determine lung diffusion and dead space estimation. And therefore, blood gases are really helpful. Yes.
Okay, thank you. Next question. I think when RER is in the normal range, but the oxygen uptake at rest is higher than 5 milliliters per minute per kilogram during resting, is this because the subject has a large body size?
Usually, yes. Patients with a higher body weight also have higher also have higher VO2 values. However, if you take the value per kilogram, you should always be around 3 to 6 milliliters per minute per kilogram. What you should do at regular time intervals is do a biological validation of your results. So you put a healthy subject on a bike. I think the most important thing is that you see this VO2 slope increase of 10 milliliters per minute per watt. And of course, if you do a biological validation, you have to make sure that the subject is really healthy. We had cases from expert centers where the head of the CPET section was always doing his biological validations himself. And all of a sudden, there was a blunted increase of peak VO2 at higher exercise levels. And he said, well, this must be a calibration problem. And he tried recalibrating the system. He tried a mechanical validator. He tried to calibrate the pedals of the ergometer. And it took some time until they found the error. And this was when he developed chest pain, when he climbed um, uh, 5 stories of steps. And then, well, he had coronary artery disease. And this was the problem that the biological validation failed. So make sure you are using a healthy subject.
Okay,
But
thank
these measurements at rest, they are a rough estimation of are the values okay or are they not okay. So for example, if you have an RER of 1.1 and a minute ventilation of 12, 13, 14 liters per minute. This is okay. If you have an RER of 1.1 and you have a minute ventilation of 4 liters per minute, it is clear that there must be some problem with the calibration itself.
Okay, thank you. So really looking at the question, so 5 milliliters per minute per kilogram should be not by the body weight, but a higher oxygen uptake
Yeah.
as an absolute value should. And you're speaking about the metabolic calibrator and biological quality control. So you also recognize there is an additional value to do both.
Yeah. If you want to be sure, you have to do the mechanical validation. Because with the biological validation, you're always relying on the health of the subject who performs the test. But of course, for the mechanical validation, you have to have a mechanical validator, or you have to have a company who comes to your clinic with this mechanical validator. So the resources for this mechanical validation are much higher.
Okay,
Yes.
thank you. I see already there are not questions, but people recognize that you did a very great presentation.
Oh,
Going
thank
back
you.
to, in case of a low oxygen uptake and reduced anaerobic threshold, lower than 40% of predicted oxygen
Hmm.
uptake, what are good discriminations of a cardiac output? I think this is always the problem. How can we estimate cardiac output, oxygen delivery problem? So peripheral problem or deconditioning, what do you use?
Yeah. Well, if the anaerobic threshold is low, um, deconditioning is not very probable below this value of 40%. So VT1 or AT is very much variable. And this is why the threshold is set very low at 40%. But if it's below 40%, probability of a pathologic process is high. And what we recommend, of course, you can predict cardiac output from certain CPET parameters. But what you would need in this case would be additional diagnostic tools. And I always recommend do an echo and try to estimate cardiac output also from echocardiography. For example, with this patient with peripheral muscle disease and impaired oxygen extraction, this was exactly the question that we had. The patient had a problem with oxygen uptake, and we did not see anything on resting echocardiography. So the question was, well, is it a central problem uh, with cardiac output, or is it an oxygen extraction problem? And what we performed was stress echocardiography with cardiac output measurements, which is an additional estimate of, well, does it increase or does it not increase? And we saw that cardiac output was increasing. And this led us to the conclusion that there must be something wrong with oxygen extraction. But cardiac output measurement is difficult in clinical practice, and you have the possibility of estimating it from oxygen pulse. However, this may not be exact because from the Fick principle, you also need central blood gases to really know the oxygen extraction value, and you don't have that in clinical practice. So your other options are performing echocardiography, or if you really want to have an exact measurement, you have to do it invasively.
Okay, thank you. I see already a lot of questions. I don't want to limit your answers, but I try to manage them. And I also recognize you are a cardiologist and going to Bosman course. This is driven by cardiologists, which is of course not, yeah, this is how it is. But I like that, therefore this question even more. What about dynamic hyperinflation? I see EFLV, so exercise flow volume curves. Do you
Yes,
use it?
yes. If you have the possibility, do it with the question of, does the patient hyperinflate during exercise? This means that end expiratory lung volume shift. And in Germany, we always have the discussion that we may add it as a separate panel, this flow volume curve, because it is non-invasive. It is easy to perform, and you just have to tell the patient to breathe in maximally, and then the interpretation is the difficulty. So how do you recognize artifacts? How do you correctly align the flow volume curve? But if you are able to do this, you should use it. And what we do is we do one flow volume loop at rest, we do one flow volume loop at light to medium exercise, and most importantly, one flow volume loop at or near the end of exercise.
Okay, thank you. And for all of you, we are planning an educational webinar end of the year with Professor Nader, Alberto Nader, and for sure he will go in more details here.
Yeah.
What about oxygen efficiency slope or oxygen uptake efficiency slope? Are you using this in your nine? It's not in a 9-panel plot, but
it's not in the 9-panel plot. And of course, you can use it. It tells you something about dynamics of VO2 uptake independent from ventilation. But for a basic report and a basic interpretation of exercise limitation, you don't need it at first sight. So what I was trying to do in this webinar was to convey, well, how can you use the 9-panel plot to get as much information out of this plot as possible. So yes, you can use it, but you also get reliable results with the basic information that is contained in the 9-panel plot.
And then regarding the next question, exercise oscillatory ventilation.
Yes, exercise oscillatory ventilation is a phenomenon that tells you something about dyssynchrony between ventilation and perfusion. You see it regularly in heart failure patients, and regularly you see it from rest up to the VT1 or the anaerobic threshold, then it may disappear and come back in the recovery phase. So exercise oscillatory ventilation is a phenomenon that is not, well, oscillating breath by breath, but it's oscillating with an amplitude of 60 to 90 seconds. And this has an implication on your data display. So for getting smooth data display, you have to do data averaging in some kind of sense. Because if you use raw data, you will not adequately see the important key points in the plot. So if you want to see oscillatory ventilation, you have to do an averaging method that comprises a time window of about 10 to 15 seconds. Because if you do 60-second averaging or 30-second averaging, this information may be lost and you will not see the oscillations. So you need a more narrow time window in order to make them better visible. So what we recommend is either a fixed 10 to 15-second interval or a rolling average of about, well, 5 to 7, 8 breaths.
Next question. This was a question many times asked. I recognize if patients are transgender, would you use born sex or perceived chosen gender?
This is a good question. Well, I would rather use the born gender. I mean, you can try both. But if you are interested in the limitation of a subject, I think that there are not much data on that. It's more helpful in our experience to use the biological sex or the biological gender in order to really get the exercise limitation for the respective normal value of the individual patient, rather than using the chosen gender. But this is just a rough estimation.
Regarding calibration verification, how many do you use by yourself on your CPET lab a mechanical validator? And biological quality control, and how many times per time do you recommend to do this?
Well, I think we have done the last mechanical validation more than 5 years ago.
This is an
And
honest answer.
yeah, this is we don't have a mechanical validator ourselves. So when I was in Carl Wasserman's lab, we did mechanical validations every day because the validator was standing next to the machine. So every morning the machine was validated. However, if you don't have the machine, it's much more difficult. So we are doing biological calibrations about every 6 months, or if we see that there is a drift in the values.
Okay, I recognize we don't sell them. They are expensive, but I heard you say you prefer a company which comes every year and give you a stamp and do use this as a kind of quality control. This would be ideal for your practical session, maybe. What do you prefer, MVV prior to CPET or estimating FEV1 times 40? So there are a lot of questions in this question, but maybe.
Yeah. Well, what we do is FEV1 measurements. If you ask the patients, what would you prefer? I think no one would say we go for the MVV measurements because this requires that you really maximally hyperventilate for 15 seconds. And to do it correctly, you would even have to breathe more than that. Furthermore, if you have patients with a significant obstructive limitation, the MVV maneuver would be more difficult, so that we use the FEV1 approach, which is a rough estimate for the MVV, that's true. However, for clinical practice, I think it works very well. And as you have previously asked the question, the flow volume loop tells you more about hyperinflation than the breathing reserve.
So I recognize
Mm,
globally it's more the Scandinavian countries use MVV and all,
yeah,
and FEV1 times a certain frequency. That's also a debate, but I will not ask this
yeah.
question for this one. There are talks measuring potassium levels instead of lactate levels. I even heard this last week on RTP at peak exercise. What are your thoughts? Is it lactate or potassium which limit the patient at the end? It's more a CPET or a sport question, I think.
Yeah. I'm not really sure. I'm not really sure whether it's one of these two parameters anyhow. Because why do patients stop? Because they feel uncomfortable. They either experience dyspnea, they experience leg fatigue, they experience pain. And I think it's a central mechanism to stop exercise. So I'm not sure whether we can reduce this to potassium or to lactate levels anyhow to make the answer short. But this belongs more into the sports field. Yes.
I recognize already we cannot win from the amount of questions, so I don't recommend
Hmm.
you to ask any more questions because we still have 5 minutes left. Does metabolic expenditure provide us with important information in exercise analysis? I hope you understand the question.
Not really.
Okay,
I'm
then
sorry.
yeah, sorry. Apologize if this was mentioned earlier, but what is the optimal drawing time for lactate after end exercise? So how many times should you wait after the exercise to find a maximum value?
This is also something that belongs rather into the field of sports
Yeah.
medicine. So for clinical purposes, we don't do lactate measurements during recovery anyhow. We do one lactate level at rest, and we do one lactate level at or blood gas measurement near peak exercise. And the art of the one drawing this blood sample is recognizing when is the point where the patient will stop within 30 seconds. Because
Right.
after you stop the exercise test, it becomes imprecise. So you have to do it at the point where the patient is shortly before stopping the test.
Do you have recommendations for normal values of end-tidal CO2 pressures and end-tidal oxygen pressures? So what are the normal values for PET CO2 and PET oxygen?
Well, there are some normal values from the Wasserman group for end-tidal CO2. They say, well, 32 is the threshold or is the upper normal limit. If a patient or a subject has unexplained dyspnea and is not able to increase end-tidal CO2 above 32 millimeters of mercury, you should have a suspicion that there is something wrong with the ventilation-perfusion relationship. In healthy people, you should clearly exceed 40 millimeters of mercury. This is what you would expect. And the second point is end-tidal CO2 has to rise during exercise. So if you have end-tidal CO2 values that are low and do not rise or even fall during exercise, this is an indicator that there is some pulmonary vascular pathology going on. And there is another value if you take blood gases. The gradient between alveolar and arterial CO2 should be negative at the end. This means end-tidal CO2 should be higher than arterial CO2. And if it is positive and exceeds a value of 5, 6, 7 millimeters of mercury, there is a strong hint that you also have a pulmonary vascular limitation in these patients.
I think you answered most of the questions. I went through the rest of them and I see one last one which is not covered, and I think is vital capacity. Has this a large contribution to VO2 max? So what is the relation with to vital capacity and VO2 max?
Vital capacity, of course, has a relationship with peak VO2 because if you don't have enough vital capacity, this means you have some restrictive lung disease, your ventilatory reserve is exhausted much earlier than in a healthy subject. And this is the problem because there is no compensation mechanism for an impaired lung volume. And thus, patients with a decreased vital capacity also should have a decreased peak VO2.
Thank you, Danielle. I have to stop because of the time, and I think again, we almost covered all the questions. And for the people who understand German and can listen, this webinar will be in German in 2 weeks as well. And again, a big thank you to Danielle again for this clear and excellent presentation. Not only because I think so, I see a lot of people responding this. Thank you for this excellent explanation, excellent presentation, and I'm with them totally. I also thank all the people who are still here in this webinar, still more than 300. Thank you, and looking forward to meet most of you again in next webinars, and we try to organize them as much as we can. Thank you. I have to close
It
it
was,
now. Sorry
uh,
if we didn't answer your last question, but this is how it is. Thank you. Do you
thank
want to
you.
say something? Yeah. Okay. Bye from my side.
Goodbye.
Goodbye. And I close it.